Hello, I'm Manoj Karmakar. I trust you are well wherever you are in this wonderful world. In this upcoming video, Dr. Shankar Hariharan from the Medical College of Wisconsin in Milwaukee, United States, is going to discuss with us ultrasound imaging of the cervical, spine, and paravertebral region and injection techniques relevant for pain medicine. If you like any of our videos, do remember to share and like with your friends, and remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
I'm Shankar. I'm calling from Medical College of Wisconsin. I would like to talk about the ultrasound imaging of the cervical spine and paravertebral region and the various injection techniques. This is where I do most of my work. I work at the VA Medical Center in Milwaukee, Wisconsin. I have no financial conflicts of interest. What I plan to do today is to review normal sectional anatomy of the cervical spine, most of which will be covered by George later on. I would like to correlate the sonographic images of cervical spine and paraspinal structures, understand ultrasound-guided injection techniques in the cervical spine. Now, I would like to, when the pandemic is over, I would like you all to visit Hong Kong and look at one of the world's tallest bronze Buddhas, which is in the Lanto Island. I had the opportunity of visiting Lanto Island almost a decade ago. And the moment I landed onto this island from the cable car, a huge fog moved in and covered my view of the bronze Buddha. And this is what I could see. But then there was a moment, this was a moment for me to imagine the bronze Buddha, which is very similar to what is happening with ultrasound images these days. Now, when you look at an ultrasound image, it requires a lot of imagination. You have to know what is the structure you're looking at, imagine a cross-sectional anatomy, and then correlate that with whatever you are seeing today. Now, the bronze Buddha looks like this, and when you actually look at the foggy picture, this is how it is, and you may have to imagine how it is going to look, and that's essentially what is ultrasound imaging. Now, when you look at the ultrasound image of the cervical spine, it's all gray, black, and white. One way of understanding the sectional anatomy is to correlate that with any of your anatomy textbooks, which will have the cross-sectional anatomy, and then superimpose that over whatever structure you're trying to visualize, and that will give you a better understanding of what the structure is. And in this case, this is one of the cervical spine. And as you can see, when you superimpose the image, it gives you a better correlation. You are able to understand this much better. And this is probably the initial steps in which you would start learning ultrasound anatomy. Now, that was a transverse view. Now, when you want to look at the longitudinal view, this is a skeletal model. And if you were to draw a line over the bony outlines, this is how it's going to look. And if you take this particular red line and put it onto an ultrasound image, this is how it's going to look. And this is your correlative Sono Anatomy. This is your occiput, the C1 spinous process, and the C2 spinous process, which is much longer or taller, and the C3. These are the posterior longitudinal ligaments, and this is your CSF and spinal cord. This is just a way of simplifying for the beginners how to correlate ultrasound pictures with the anatomical knowledge that you have. Now, there are different ways in which people would understand ultrasound images. One of them is to have a 3D image of whatever you're trying to look at in your brain, and then correlate that with the ultrasound pictures. And that requires a little bit more training, little bit more practice with your ultrasound images, and then you will get it. what I would like to do is I would like to go over the um, ultrasound images of the cervical spine from all the different angles. Now, when you start looking at the posterior view of the cervical spine, you can see the spinous process. And then from the spinous process, it goes down to form the lamina. And then you have the paravertebral muscles. Your transducer is placed in a transverse view. Usually we use a linear array transducer, as you can see, because the penetration depth is small. Moving on to a longitudinal view. Here, I'm using a curvilinear so I can see multiple different spinous processes. That is the only reason why I'm using that, just to demonstrate that you can see many of them. When you move slightly to the lateral side, the Paramedia view, you have different types of structures that you're going to see. And most of them will be, depending on how the cervical spine is rotated. You can see some articular pillars. You can also see the lamina. You can also see depending on how big the patient is, you can see the epidural space or interlaminar space. If I were to look at it from the lateral side, what I can see will be some of the transverse processes. And between the transverse processes, you would actually be able to see the nerve roots coming out. And that is what you're seeing in this particular view, where the stars demonstrate the various nerve roots coming out of the foramina. If I were to move from the lateral side anteriorly, this is the view that you're going to see, where you're looking at some of the transverse processes, the pillars of the transverse processes. You can also see the vertebral artery between the transverse processes, and the muscles in front of it would be the longus colli, depending on where it is, longus colli capitis, and as well as the carotid artery. As you all know, the vertebral artery can be identified using color Doppler, which is very, very useful to have whenever you are doing any neck injections, because this is an area which has pretty significant major arteries. Starting from the C1, if you were to start scanning gradually downwards, the first spinous process is very small, almost rudimentary, and it has a lamina, which you can see in the transverse view. If you were to look at it in a longitudinal view, this would be the spinous process. And this is a posterior longitudinal ligament as well as the CSF and the spinal cord. This is your potential epidural space. Now, the next C2 is very, very important landmark because it has the first Bifid spinous process, as you can see here. The first Bifid spinous process serves as the landmark for you to identify and locate the subsequent levels. In a transverse view, you can identify the Bifid spinous process. And as you can see, it is one of the tallest spinous process in a longitudinal view. The major joint involving the C1, C2, the atlantoaxial and the atlanto-occipital joints, those are areas where sometimes we do inject. And we must remember, we must be cognizant of the fact that the vertebral artery takes a circuitous route moving from lateral to medial when it comes to that particular area. So if we were to inject into the AO joint, we need to make sure that the color Doppler, make sure that we pick up the vertebral artery using a color Doppler and then try and steer away from it before we inject the atlantoaxial joint, atlanto-occipital joint. And similarly, when you go to the atlanto-occipital joint, atlantoaxial joint, which is between the C1 and C2, you again want to check for the vertebral artery, which is more likely to be in the lateral side of the joint. These are demonstrations showing you the location of the vertebral artery at these two locations. Now, the other interesting feature about the sectional anatomy of the neck is that there are multiple muscles, and it helps to understand the muscles that you are looking at in order to detect pathology, as well as to have a better understanding of the anatomy, the Sono Anatomy in that particular area. So this is the, I have removed the trapezius for you, and what you can see is the scalenes in the front, and more laterally, more posterolaterally, you can see the semimembranosus as well as the levator scapulae. Now, when you remove that, you can go deeper to see the semitendinous. I'm sorry. This is your levator scapulae going from the scapula upwards, and in front is your anterior and posterior scalenes. When I remove that, then you can see anteriorly, you can see your scalenes very clearly here. And here is your sympathetic chain, and more laterally is your internal jugular vein. This sympathetic chain goes all the way up and down, which we will talk about a little bit later on. Now, posteriorly, it has, in the suboccipital triangle, it has some very interesting structures. Now, when you look at the suboccipital triangle, you have the obliquus capitis inferior at the bottom. This travels from it is inserted both into the spinous process of C1 as well as the transverse process of, from the spinous process of C2 to the transverse process of C1. Now, why is this important? Because of the greater occipital nerve, which is laying right above it between the, as you can see, it is right here. That is the location of the greater occipital nerve. And I'm going to show that to you in a transverse section. If you were to orient your transducer, moving from the C2 spinous process to the C1 transverse process, which will be in line or parallel to the fibers of the obliquus capitis inferior, this would be the view. Now, I'm posting two different images here. And the first one is when you get a transverse view at this location. Now, what is happening is you're not seeing the parallel fibers of the obliquus capitis inferior because of the orientation. Once you orient the transducer towards the C1 transverse process, then you will see the parallel fibers of the obliquus capitis inferior. Right above that is your semispinalis, and between them is your greater occipital nerve. The other important structure that is in this area is your third occipital nerve. The third occipital nerve travels over the C2-3 facet joint before it goes on to the occiput. Now, these are the different structures which you can see whenever you are scanning in this area. The various muscles I have labeled, but the most important muscle that is going to be in close proximity to the third occipital nerve will be your semispinalis capitis. Now, there are two locations where you can identify the third occipital nerve. One is over the C2-3 joint, as I mentioned to you. The other one is when you're looking for the greater occipital nerve, the third occipital nerve is likely to be much more medial and closer to the spinous process of C2. Moving on to the superficial cervical plexus, which is located approximately at the level of C2, 3, 4 vertebral levels. What is the most important location is the posterior border of the sternocleidomastoid. The three nerves of the superficial cervical plexus is located just beneath the posterior border of the posterior border of the sternocleidomastoid. And sometimes you will find the greater auricular nerve just above the sternocleidomastoid. Deep cervical plexus can be located by identifying the levels again. If you start from the C4 level, you can watch as the nerve roots come out of the foramina, and then that would be your deep cervical plexus. Moving further down from C4 to C5, what is interesting about C5 is that it has almost equal, almost level anterior and posterior tubercles of the transverse process. And you can see in a transverse view, you can see the C5 nerve root exiting the foramen. Just above that will be your longus capitis muscle, and medial to it is your longus coli muscle. I have squished the internal jugular vein, as you can see right above. Now, there is, if you were to look at it in a longitudinal view, this would be the longitudinal view of the nerve. Why am I looking at a longitudinal view is because sometimes you will find in patients with avulsion injury of the brachial plexus, you will find a neuroma at this location. You can also identify the suprascapular nerve as it exits from the C5 nerve root. The other thing to look for in a C5 nerve root is when you're doing a selective nerve root injection, you want to target the posterior tubercle of the C5 nerve root. And that would be your location. And before you do that, you definitely want to check with color Doppler to make sure that there are no arteries in your trajectory. This is something which most of you know, the brachial plexus. What I'm trying to do here is I'm trying to trace it for you from the foramina all the way back into the brachial plexus. Just for practice, you can say, but I want to stress the importance of identifying the structures based on their origin. So now you can be sure that the grapes that you see in your intercostal, in your interscalene block, do actually come from the nerve roots from the foramen. Moving further down to C6, you have the Chase-Nax tubercle, the anterior tubercle of the C6 cervical spine. So here you have the vertebral body medially, and you can see the thyroid just above that. The anterior tubercle, the Chase-Nax tubercle, is the tallest tubercle that serves as a landmark for you to identify the various levels from there on. This has also been used to do a cervical sympathetic block in the past, but these days we try to identify a better trajectory, which I'm going to show you later on. This is the anterior tubercle of C6, and this would be the posterior tubercle, and the star is the C6 nerve root. A way to correlate that would be to outline the bony structures, which would appear as hyperechoic, and then you have the acoustic shadow beneath it, which will help you to identify the structures much better. The other way of looking at it would be to superimpose, like I said before, a structure that you know onto what you have here, and this is how you would correlate the images. Some of the muscular structures in this area, you have, like I mentioned, you have the longus coli, longus capitis, which starts at C6. So if you see the longus capitis, you know that it is the beginning of C6. And more laterally, you have the anterior scalene. Moving further down to the vertebral body of C7, as you can see, there is no anterior tubercle. And usually it is a very rudimentary posterior tubercle, but you can see the nerve root very clearly, and above that is your anterior scalene muscle, and medially is your longus coli. Some of the interesting things that we do in the neck as pain physicians is cervical facet joint injections. Facet joint injections are usually located using a transverse view, with the patient laying onto his lateral side with the injecting side upwards. So if you were to use a curvilinear transducer, you're able to see multiple levels. But then you must remember that Not all levels are going to be symmetrical. So you may have to adjust, fine tune at each level. I most often use a linear array transducer, where in younger individuals, you can actually see the facet joint. And this would be the C2-3, and this would be the C3-4 joints. And moving on, you will also be able to identify the medial branches, which will be in the valley of the structure. The hillock, in the top of the hillock would be your facet joint, and the medial branch would be located right here. I would encourage you to mark them before you actually do the injection, because these joint lines will look very similar at multiple levels. Another way, which is popularized from Canada, is to locate the articular pillars. As you can see, the articular pillars are here, and this is your anterior tubercle and posterior tubercle. So if you were to locate your needle right here at the anterior articular pillars, you will also have spread over to the medial branches. As always, you want to make sure that besides the carotid artery, there is the vertebral artery, which can cause major issues if you inject intravascular. And that is usually identified by using the color Doppler. They do not show up because of the bone here in the transverse process, but just outside of the transverse processes, you can locate them by using the color Doppler. Now, the other major artery that you also want to know about is the inferior thyroid artery, which is usually located just beneath the carotid artery, and it'll move on to the inferior portion of the thyroid gland. You do not want to inject in or around it because it can cause bruising, it will cause a retropharyngeal hematoma, and that can cause difficulty in swallowing. Talking about swallowing, you definitely want to make sure that you locate the esophagus. People have injected into the esophagus, and it's a total waste, as well as the potential for causing infection or spread of infection from that area. So you want to ask the patient to swallow, and air bubbles will be seen floating down as you locate the esophagus. So in this particular small video clip, what I want to show you is we were trained to inject at the level of the C6 for doing your cervical sympathetic blocks. But what I want to show you is a better location based on the trajectory, based on what are all the safer structures, and the proximity to the cervical sympathetic stellate ganglion, or the inferior cervical ganglion. Now, the reason why you want to do that is much more specific for the sympathetic innervation of your upper extremity. We all know that the cervical sympathetic chain travels just beneath the prevertebral fascia located on the longus colli muscle. And here you can see the inferior thyroidal artery right there. So if I were to plan on injecting here, it will be very difficult. You can see the longus capitae here, but still, I would like to go much, much closer to this T1 or C7 spinous process, C7 vertebral level. Now, the way to do that is to start from there, C6, and start scanning down until you lose the anterior tubercle. And you can see here, you have lost the anterior tubercle, and you can only see the posterior tubercle. That is at the level of C7. This would be a much better target for your stellate ganglion block because you don't have major vessels here, but you must remember that the vertebral artery is much more in the open here, and you want to make sure that you identify that before you do any injections at this level. So the trajectory that I normally follow for injecting the stellate ganglion is based on what is located in that area. In other words, I do a scout scan to identify what are all the structures there and determine a safe trajectory. And here, as you can see, there are two possible locations where I can inject. But then, if I go medially, I have the potential to damage the inferior thyroid artery. So a lateral almost an oblique. This is not ideally an in-plane technique, but it is almost an oblique approach to the prevertebral fascia covering the longus colli muscle. Now, you can also be cavalier by injecting between the carotid and IJ if that is the only possible location for you based on your trajectory planning. And here I'm showing you how you can approach in an out-of-plane approach between the carotid artery and the IJ without damaging either one of them and injecting into the cervical sympathetic chain at this level. And with that, I thank you all for listening, and I'm looking forward to listening to the other professors talk. Thank you.